lactation and adoption, the bonds beyond biology. We also are going to explore the biological bonds and what is beyond biology, the emotional, the social bonds that can exist because of induced lactation and adoptive lactation, with our prominent speakers, Dr. Zahara, Dr. Carleen, Dr. Safinez, and our Egyptian prominent speakers, Dr. Rania Al-Farrash and Dr. Asma Saad. Please, Dr. Zahra. Dr. Zahra is going to be our first speaker. Dr. Zahra is a medical doctor and a lecturer at the University since Malaysia. I hope I'm pronouncing it right.
Yes, that's correct. Yep, that's correct.
School of Medical Sciences. She's a passionate expert in lactation and breastfeeding. She has been certified as International Board Certified Lactation Consultant since 2007. And currently leads the lactation unit at University Sains Malaysia Specialist Hospital. Dr. Zahra and her dedicated team have been providing induced lactation services while also advancing in research, publishing academic works, and developing treatment guidelines for the hospital. Her educational contributions include authoring reference manuals for breastfeeding peer support groups and developing online breastfeeding training modules. She's a committed advocate. Dr. Zahra has served on the local government committee of the World Alliance, local governance committee of the World Alliance for Breastfeeding Action, WABA, since 2014. Her long-standing dedication to breastfeeding promotion, support, and advocacy has earned her esteemed international recognition, including fellowship from the International Lactation Consultant Association, ELCA, as well as the Academy of Breastfeeding Medicine, respectively 2023-2024. Please, Dr. Zahra.
Thank you very much. Assalamualaikum and very good afternoon, good evening. Can you hear me?
Yes.
All right, okay. Sorry, I think the video is not working well, but as long as you can see the slide and you can hear me well, I think that's good enough. First of all, Alhamdulillah, I would like to say thank you to the ELCA, to the Egypt Lactation Consultant Association for the invitations. Okay, I was told that I have about 25 to 30 minutes to talk about this topic. Okay, so my topic tonight or today is about building evidence in the field of induced lactation research. So let's just see first the things that I'm going to cover. Just a slide on induced lactation adoptions, and then I'm going to talk about research and publications on induced lactation. And then what are the limitations in the current research methodology that we are actually facing? And next one, I'm going to talk about the challenges in conducting clinical interventions research, if there is any. And lastly, way forward in building evidence and research field. Right, so just an introduction. As we know, when we talk about induced lactation, it is initiating milk productions. The main thing about induced lactation is that in a person who has never been pregnant or give birth, okay? Compared to relactation, when someone needs to re-establish milk productions, it means that the woman has already had some kind of experience previously. For some ever reason, she has to stop and now she wanted to start again. Definitely, these two conditions are different, and today we are focusing on induced lactation. Okay, but in both cases, whether it's induced lactation or relactation, most of the women usually will use some kind of galactogag, whether it's natural, whether it's drug or herbal, as an agent to increase their milk supply. Okay, so today we are going to see some of the research that have been using, talking about this galactogag as well. All right. So this is the introductions of induced lactation. Okay, but when we talk about adoption, so in Islam, or another term for that is al-kafalah, or fosterage, right? When someone care for another children, whether from young or from older. But the main thing is that without connecting the child's parentage to the adopted father, and this is what is allowed in Islam. Okay, and because they are not the child of the parentage father or mother, so there is some kind of restrictions, for example, auras, or touch or interaction that the child need to observe before she becomes her mahram. So in order to make the child mahram or become part of the family, but even though she's not or he is not a non-biological children, is by breastfeed the child at least 5 times or more in the first 2 years of life. Okay, this is what one of the main reasons I would say why Muslim families or Muslim couples who actually adopted a son or a daughter go through induced lactations. The main aim is actually to make the child mahram relationship with them, so that, for example, in the future, if they have like children, they are actually siblings. Okay, so I think these are the main reasons between Muslim and non-Muslim in terms of why they wanted to do the induced lactation. Of course, there are many other reasons why people do it, but this is one of the main reasons for the Muslim. All right. So let's talk about our topics regarding the, advancing in research in induced lactation. If I just ask everyone here, when you just Google the word induced lactation, or you go to Scholar Googles, or you go to PubMed or anything, right? So if you write down like induced lactation research, or induced lactation methods, or how to induce lactate, like, okay, drugs for induced lactation. If you Google all these words, um, perhaps the things that come out will usually talk about whether what's the protocol used, in induced lactations, or sometimes usually you will get like topics like clinical experience or case studies. This is a lot of papers that talks about induced lactation, whether the experience comes from the practitioner or the experience actually comes from the respondents, or the experience is actually or case studies regarding the drug side effect that the mother actually experience due to the side effect of certain drugs that she took for the induced lactation. Or sometimes you can also get papers that are talking about data or statistics or reviews about induced lactation in certain region or certain countries or some local data, right? So of course there are many other papers that you can get, but in general, when we Google or when we try to search on induced lactation, it's either about protocol or about experience or clinical studies or some data or statistics or review. Okay, so let's just have a look first at the first one about the protocols. I know one of the speaker will talk about the future of these protocols, but I'm going to just touch a bit about some research regarding these protocols. Okay, so in general, when we talk about the protocols for induced lactation, okay, we can see various types of protocols. Okay, definitely for those of you who are actually familiar in induced lactations, some of them use drugs, some of them don't use drugs, some of them use natural remedies, some of them just use technical stimulations, things like that. Okay, but one thing that we can agree upon is that at the moment there is no standardized protocol agreed upon everyone, like CPGs. We don't have that kind yet in at the moment. But what the current papers is actually looking at is by Chanel, where she actually introduced the 3 steps framework for induced lactation. From this framework, what she found that, whatever the protocols that people are using, somehow they can be actually categorized into these 3 steps. Okay, steps 1 is actually preparing the breast. Step 2 is starting to make milk, and then step 3 breastfeeding and making more milk. Okay, so but how each step is being done is actually much different from one study to another study. Okay, there is no like one single study that actually explain very well, similar with other studies. I'll give you one example here, what Chanel actually summarize. Okay, so this is the step 1. We know in preparations of the breast before the baby actually arrive, And then the second step is starting to make milk, and step 3 is feeding baby, making more milk. Okay, so if you look here, these are different authors. Okay, different authors at different years. For step 1, some authors use multiple ways of preparing the body and the breast. Some authors didn't actually explain about that one. They go into straight step 2 and step 3. Okay, for example, the study only use drugs, estrogen. Some use drugs, estrogens and progesterones and domperidone, since starting from step 1. Okay, and some of them here use both supplements, skin to skin, drugs, hormones. Okay, so the different what they are saying here is that what are being done for each steps are different, but in general there are actually 3 steps in making the induced lactation milk productions. Okay, so this is where the agreement is at the moment is not achieved yet, because like I will explain why different study have different protocols. Okay, I show you another example here. Right. So again here, I was finding this is very interesting. For this one paper, for step 1 they use visualizations, but I didn't go into details like, wow, okay, like how you visualize the breast is producing milk, and how does that actually helps in terms of the actual physiological change. But anyway, there was one study looking at that, how visualizations, and then starting this step 3. Okay, the thing is that when you look at step 2 here, starting to make milk before baby arrive, if you ask me in Malaysia, most of the time when the mothers come and see us, the baby has arrived. The baby arrived much earlier than the mother come and see us. Sometimes the baby has arrived early a year, like 1 year with the mother. Then only the mother realized that, oh, there is a way to do it. Then they come and see us. So uh, at certain places, of course, this is ideal. The step 1, step 2 gets very nicely put together, expecting the baby is not there yet. But if you ask me, in my experience back in Malaysia here, most of the time when the mother comes, sometimes the baby already more than 12 months old, sometimes can even walk or run, and when they come and see us. So of course it's a more challenging, because they are having lesser time to achieve the mahram status. Okay, so what I want to say here to you is that there are many ways of doing for each step, but most of the study agree that there are 3 steps that need to be fulfilled: preparation, starting to make milk, and feeding more milk. Okay. All right, so I just give you some examples of a few protocols that are available at the moment. For example, this is the traditional one. In the traditional, when you look at this is one of the study, a bit G, is it? Okay. But when I read the explanation, this is not really induced lactation. This is actually uh, feeding the adopted child. Okay, because like the woman has already had previous experience. That's why when I look at here, this was more easy just by traditional stimulation, just by breast stimulation. But when you look into that one, they already have experience. Lactation was initiated by sucking this participant begin to produce blah blah blah. But if you look into the details, this mother usually have already previous experience. So the title actually say induced lactation, but if you look into details, this woman actually had previous experience, so it was not a true really induced lactation in this case. Okay, there are the protocols here, like for the Avery protocols, whereby in Avery they actually emphasize the time before baby arrived. Emotionally attuned it. Okay, this was one of the, I think many people quote this study because she has a big number of participants in the study. Okay, and how the importance of manual stimulations of the breast. And then this is what they want to say: stimulation is the most important. Stimulation is important. Drugs is secondary. If you don't stimulate, no matter how much drug you give, it will not work as well as if you stimulate the breast. Okay. And then there's another one, pumping. This is pumping protocol, West and Marasco, okay? And this protocol emphasizes a lot about physical techniques, okay? And if you do a lot of stimulations, as medication become the secondary. And we know that, I mean, we have friends from Philippines who actually done this, purely on massage and stimulations without drugs. And it works, because that's how they actually do the protocols. All right. Okay, so if we look into the literature on current methodology, okay, we're talking about what are the evidence of the current methodology, right? So if you Google, most of this experience has been captured, has been shared in manuscript in a journals as report or case series, or they actually talk to us in observational studies. They observe a group of people, follow them through some cohort studies, okay? But of course, when you do this, like for example, in a case report, they lack generalizability because they usually just explain about one or two patients or mother, So it's very, very specific. So you cannot generalize that perhaps in different situation. Observational study, when you observe, they are actually limited by confounding factors. There are a lot of confoundings because you cannot control the confoundings. And if you read into systematic reviews or meta-analysis, usually the author will say at the end of the analysis that most of the papers here are heterogeneous, and because they have to include many studies that are not strong in conclusion because they are not focused in the same area good enough. Okay, and quite a lot as well when people in talking about induced lactation, they actually do qualitative
صرت
study.
ولا يبروف
Okay?
هذا خاطر هو
Like,
قال لك
for
اوكي
example, the study explore on the life experience. They talk about what are
فما
the challenges these women face and things like that. Okay, there are a lot of
ايش في
qualitative
ايش في
study, which I also do this a lot with my
كونفيرم
students, my PhD
كونفيرم
students
ده
and
هاد
masters
خلاص
as well. All right. Is it okay? Can I continue? Someone talking? No? Is it okay? All right. All right. I just continue. Okay. So these are some of the examples. Okay, articles in the reviews. So if you look into the design, it's like the case report, qualitative case report, case report, case report, case report. Okay. So when you have a case report, so how many samples do you have? One woman, one woman, one woman. Okay. And because there is only one woman, the explanation is very, very specific to just that person. And if you look into this, how can you compare that, these methods, this method is actually they use hormone, HT is hormonal. This group, this three experience doesn't have any hormonal, So it's not that easy to compare in terms of like evidence base. We can take each one of these as an example, but if we want to say a big conclusion that, okay, in general, we cannot do that because the sample is very small. And this is what is the challenge at the moment to do research on this. So what are the, as I mentioned, the evidence, what we see, what I just showed you, small sample size, one case, two cases, and heterogeneous protocols. Some use hormones, some that doesn't hormones, and they don't have any control group if you look into the evidence that we have at the moment. And lack of long-term follow-up. Usually this paper just report a case or two, and then they just tell us what is happening at that time. And usually there is no follow-up, like after 6 months or after 12 months, what happened to the mother, whether she can actually continue breastfeed or not. Okay. And last one, this is what I also find, that subjectivity of success, how a woman perceive that I have become successful in induced lactation. Is it when the milk just come out, or is it when the baby get mahram, or is it when she is able to do skin to skin and baby can be quiet at the breast, or what does it mean by success? Because different studies describe success differently. Even the mother describes success differently. Okay, so even though I mentioned just now that there were so many case study, but I want to give you just example here. I mean, if you go into Urbeck and also Golfop, okay, these were the two early studies in the 1981s and 2010 that has more than 240 women or respondents and 228 respondents. But both of these were actually descriptive studies or qualitative studies. Okay, so they describe but not really like interventions studies. The latest papers that I got actually for this, when I found this 2025 induced lactations in Iran, they actually recruited 170 non-gestational mothers, but still this is descriptive analysis. It's not an intervention, doesn't have any control. We don't really know, like, whether this mother, were given certain dose or not. So, but still, at the moment, at least the number of respondents is bigger. Perhaps you can have like a more statistical analysis, which is more reliable, okay, with the bigger number, okay. So if we look into levels of research evidence, I'm sure every one of you have seen this pyramid of evidence in research. At the moment, most of the research in induced lactation were at the lower level here, whether it's actually on case series or case report, or not even this, or some have some cohort study. Okay, so if you want to have a more evidence base in research in induced lactation, perhaps we have to think of how can we do it. Is it possible to have this kind of intervention studies in induced lactation? Okay, so what is actually if we can like design and a good study for induced lactation? This is a randomized control trial. Okay, in any study, we know this is the gold standard. But is it ethical? That's the question. Is it ethical for us to actually just randomize women who wants to do induced lactation into like getting this dose, getting another drugs? Because that is the challenge. At the moment, in our practice, whatever we give to the woman is based on what the woman can adapt and can based on her medical conditions and her medical situations. We know, like, I mean, I'm not sure about in different country, but in Malaysia, if once the woman is above 40, we try to avoid any estrogen hormone. So because that is to reduce the risk of any getting of any risk of cancer and many things. So of course we know this is the standard, but is it ethical? That's the question. Okay. Prospective cohort studies, we see that just now there were a few studies that did the cohort study. The thing is that follow over time, there are so many confounders that we cannot control, and at the end of the day we are saying, what do we actually really measure? Okay. So these are the things that are actually good to do, but at the same time, is it ethical to do? That's the questions that limits the explorations of the randomized control trial. Okay, so the main challenge here in doing like intervention studies or control studies in this lactation is the ethical concern. Besides that, the ethical concerns as well is the use of label use of medications like domperidone. In some countries this is illegal, it is not allowed. In Malaysia it is allowed, as long as you explain to the women and they understand that. So these are the things, the drugs that we use. There's some ethical concerns. And the recruitment, that is another challenge. How can we get like so many women at one time who wants to do it at the same time? That's a bit challenge, because this is the area where it's very novice and not many people are doing that. So if you want to get many people at one time, usually it takes longer time. That is not possible to do that. And another challenge, as I mentioned, the protocol is variability. I've seen like practitioners who do without any medication, without any drugs, and some of them use heavily on drugs, and some mix drugs and non-drugs. Okay, but what we do in a hospital in USM here, we will tailor the needs of what the patients want and what is actually in terms of suitable for them in terms of their medical condition. So we try to blend what they want and what is suitable for them. Okay. So, and another thing I mentioned just now, one of the other challenge is how do we measure success in induced lactation? Of course, there is, some is tangible measurement, some is intangible. Intangible, like psychosocial, or intangible success. Many women said, "Oh, at least I can feel the motherhood, even though I'm not able to get pregnant and actually to give birth. At least by doing this lactation, I have the experience of, giving the baby my milk." So that is something parental satisfaction. And marham status is one of the main success factors for Muslim, as I said, and mental well-being. Okay, but if you want to measure the real measurement, like, okay, if the baby get the milk from the mother, maybe the functional is to measure the infant weight gain. But how possible is that to do that? Because most of the time the adopted child usually just get a certain amount of milk and he or she will be supplemented by other types of milk, because the milk that the mother produces is not enough to give the exclusively for the baby. Okay, so this is what is good to measure, but it's not that easy to measure, because as I mentioned before. Okay, milk composition, yeah, this is biochemical, whether this is suitable or not at the moment. There's no, like, I didn't find any study that look into three all these things, but there are many people looking into the psychosocial or into mahram status as measuring what success is all about for their in this lactation process. Okay, I'm just looking at my time. Okay, I have a few more minutes. Okay, so where do we go here? We know what is ideal, the intervention study, randomized study. That's the ideal if we can go there. But we also understand the limitations and the challenges that we are facing. So the contribution of the clinicians still plays a big role. The clinicians and their direct patients contact, actually they are the one who can actually share with us all their experience, what they can do and share with us. For example, in the clinical documentations, in the case study, in the case series, it's good to actually give a very details what hormone they use, what dose they use, how long they use, any side effects or not, how they use the pumping, the stimulations, the massage, and this need to be explained in detail, so that something that people can duplicate, and if they want to. And the most important things to address whether there is any adverse effects in doing this. Okay, um, this is some of the works that we do in our hospital, and this is our latest book about managing induced lactation, making breastfeeding possible without birthing. It's 7 chapters, and we explain every single steps. And the most important part in this book, we are actually including their pre-counseling sessions. We want them to have like a reasonable expectations about this process, because some of them think that once they start this process, the milk will come instantly. That's what usually people think. So we want to make sure that they achieve their expectation well. Okay, and so in this book we explain every single things, like how much they need and how to do it, like how to keep their milk and how to give back the milk to the baby, and how to chart everything. And we explain about the challenges, and a few other things as well, right? So these are some of the things that we do here in our hospitals, and while doing that, we also write papers and share with other people's regarding the findings of our patients. We try to minimize the dose as much as we can, because we know that stimulations is the main key, and drugs is actually the supplements of this to get it really work well, right? All right, so I think that's all the time that I have for these sessions. I'm more than happy to answer any question if there is time for me to do that. But these are some of the references, and below here are the references of what we do in our hospitals. Perhaps if you want to have a look, you can refer to that. And with that, I thank you for your attention. If you have anything, you're most welcome to contact me at my email as stated below there. Assalamu alaikum, and thank you very much. I pass back to the MC.
عليكم السلام ورحمة الله. Dr. Zahra, I think, does anybody have questions for Dr. Zahra? Now we can see you, Dr. Zahra.
Oh,
Are
you
you
can
there?
see me now?
Yes.
Oh, Alhamdulillah, you can see me now. Okay. Thank you very much, Dr. Amal, for the time and for
Most,
for the opportunity.
most welcome, and you have given us an overview about how we should act, mainly to obtain like solid evidence.
Yeah.
But I have a question for you, since
Yes.
others don't have questions. Did you find from reviewing the literature trends that are different from what you encounter in your practice? Like, for example, especially for Muslims and non-Muslims?
Mm-hmm. Okay. As I mentioned to you, the pressure is more for the Muslim, if you ask me, because
Yes,
they have that 2 years period. I
yes,
have experience of a mother came to me when when the baby is a year and a half.
yes.
She only had like 6 months.
6 months. Yes,
Yeah, but I said to her, okay, I can help you. There is no magic. Everything
yes,
is received from Allah, but these are the steps. If you commit, if you can do this, we are more than willing to help you. Alhamdulillah, she managed to get the mahram, and because
yes,
she understands the expectations.
yes,
So these are the things that the thing like. But for the non-Muslim, usually they want to do it as long as they have the experience of holding the baby, using the SNS, get together, the bonding, and they don't really aim for the mahram because to them that is not important. They just want to have their feeling of motherhood. So these differences, I would say, make the pressure more for the Muslim couples because they want to really achieve that before the baby is 2 years old.
yes, yes. I think the age will also be something. I am speaking from our experience. Usually,
Uh,
who those who resort to such to induced lactation for adoption
yeah.
are those who experience difficulty in getting in conception. Those
Yes.
who have experienced infertility issues.
Yes.
So by the time they think of induced lactation, they are already above 35 or even 40.
Yes.
So
Yeah.
they will not be able to take OCPs, for example.
Mm-hmm.
I
Mm-hmm.
think this is an issue for us.
Right. So
Yeah,
for us, 40 is the age limit. But once
yes,
they are above 40, we only give them progesterone only hormone, and
yes.
that works. Our older patient was 49 years old, and she
Mm,
managed to actually attain her mahram by using just progesterone only drugs. Yeah,
yeah, that's great.
alhamdulillah.
And also, you mentioned that usually the baby is there, so we are
Yes,
yeah. So we don't have time for like priming the breast, and this is the
exactly.
case. This is the case also in most Muslim countries because we don't have surrogacy, and we can't
Yes,
expect that the baby when the baby will be born and will be put there for adoption. We don't have this experience in Muslim countries.
exactly. But I still do the priming even though the baby is there, at least for a month or a
Yeah,
cycle of hormone, because to me that is very important for the breast to actually grow a bit bigger, for the gland to actually grow, because that will help a lot later on when the milk wants to come in because the breast is ready. So I explained to the mother like in here we do actually, even though that we still do step one, step two, and step three. Only that we
they are
try to
accelerated.
accelerate that. Yeah.
Mm. Thank you, Dr. Zahra. Thank you very much.
Alhamdulillah. Thank you very much for the opportunity, and I wish you all the best for the next one. For the next speaker, I'll leave it now then. Thank you, Dr.
Yeah.
Amal.
Thank you. Thank you, Dr. Zahra.
Okay, assalamualaikum.
Alaikum assalam wa rahmatullahi wa barakatuh. Now we are going to be there with Dr. Caroline Gribel. She is going to have her presentation, or she had her presentation pre-recorded because it's past midnight to her now. So she can't be with us in person. Dr. Caroline Gribel is an adjunct professor in the School of Nursing and Midwifery at Western Sydney University. Dr. Gribel research focuses on breastfeeding, child rights, and the physical and mental health of infants in situations of adversity, including during emergencies and disasters, and in the context of trauma and child protection concerns. She also has an interest in health communication in women's reproductive health, a new motherhood, and in data collection on sex and gender identity. Now we have the recording of Dr. Carly.
Thank you very much. I'd really like to say how pleased I am to be able to present at the conference today about relactation and induced lactation. I hope you find it interesting, and then there's some useful information for you. So just to start right at the beginning around relactation and induced lactation, it needs to be appreciated that breastfeeding is robust. Lactation is a robust physiological process which until recently was absolutely necessary for infant survival. Women who've not recently or ever given birth can produce milk. We call it relactation for women who have ever lactated, even if that was many years ago, in fact, decades ago, and induced lactation for women that have not ever been lactated. And the difference between these two groups of women is that the final stage of breast maturation, mammogenesis, happens during pregnancy. So women who have been pregnant have had this final stage, and those who haven't. So that's where we have the difference between the two groups of women. I've got this photo here. It's from one of my favourite papers. A lot of the knowledge around relactation and induced lactation was lost in the 20th century, and was really only began to be regained in the second half of the 20th century. And this is one of a paper that was published in 1956 in the Journal of Pediatrics. And it was actually describing something that was seen as being really unusual at the time. So it was in South Africa, and they'd noticed that there were these grandmothers, they'd been babysitting their grandchildren, they'd been putting the children to their breast to comfort them, and they'd started to produce milk. And it was seen as being such an odd thing that they wrote this paper, and they included this photograph here to actually prove, you can see the milk squirting out of the nipple, to actually prove that these women actually were making milk. So we know a lot more now than what we did then. So how does lactation normally happen? Just a really brief overview. During pregnancy, we've got the hormones estrogen, progesterone, and prolactin, which act on the breasts to prepare them for lactation. And then women start to make breast milk, the process of lactogenesis 1, from around week 16 of pregnancy. And then when the baby is born and the placenta is removed, progesterone levels drop very quickly, and the breasts start to produce large quantities of milk. So the process of lactogenesis too, and women get those very full breasts anywhere from sort of day 2 to day 5 after birth. So relactation and induced lactation work somewhat differently. Without pregnancy, prolactin alone can develop the milk-making structures, the ducts, the lobes, alveoli, and lactocytes within the breast, and enable milk to be made. So there's no need for a pregnancy, there's no need for estrogen and progesterone. Prolactin can do it on its own. Prolactin levels can be raised by nipple stimulation, by a suckling baby, or by breast pumping. And unlike what happens with lactogenesis 2, this milk production happens gradually. Relactation and induced lactation have been reported for millennia. This is not a new thing, and they are normal, natural processes. And I'm just sharing, this is the image on the right-hand side. This is a book or booklet that was developed by the World Health Organization, published in 1998, so quite a long time ago. But it would still be the best summary of relactation that exists, and you can download it freely from the WHO website. Breast stimulation and milk removal, how do we arrange that? Well, breast stimulation can happen with the suckling of the baby, or using a breast pump, or hand expression, or a combination of these things. Frequent suckling, 10 to 20 times a day, is the best method if the child will agree. And for a variety of circumstances, you know, children, especially depending on the age of the child, they're not always agreeable to suckling. They've been used to bottle feeding. But if you've got a very young baby and they're willing to suck a lot, then relactation and induced lactation can be simple and easy. So anything that can be done to provide uninterrupted access to the breast, so carrying the child rather than using a pram, co-sleeping with the baby, using the breast for comfort, and just encouraging breastfeeding as much as possible, that will really help with relactation and induced lactation. And I've got a photograph here. This is actually from Myanmar after a cyclone. And this woman is not the mother of that baby. The baby was abandoned at her home. Her youngest child was a teenager, and she was supported by the organisation Save the Children to relactate, to breastfeed that baby, because in a disasters, relactation and induced lactation can be absolutely life-saving, and so difficult to feed babies otherwise. So if the child is not breastfeeding, women can use a double electric pump at least 6 to 8 times a day for 10 to 30 minutes to provide that nipple stimulation. And use hand expression as well to remove small amounts of milk. So once the milk starts to be made, using hand expression can remove the tiny amounts of milk that a breast pump won't. But it's also important to note that some women are not able to express milk with pumping. You know, even women who've got an abundant milk supply sometimes will have a lot of trouble expressing milk. And women in that circumstances may do much better with relactation and induced lactation with a baby suckling. When women start to make milk, they should aim to express a small amount more every day, and just, you know, tiny amounts extra can, it snowballs, it builds up from there. Or decrease supplementation if they're breastfeeding the baby by a small amount every day. So as little as 5 mils. It doesn't have to happen quickly, but that gradual, those gradual changes can actually make a big difference. And the photograph here on the left shows one woman's relactation process. So this is, these are small containers that contain about 50 mils. And you can see each line along the side shows the increase of milk expression that was happening every day. Medications for relactation and induced lactation. So there are 2 different types. Firstly, galactagogues. These medications increase the women's own secretion of prolactin. There are different medications used in different parts of the world, including domperidone, sulforide, metoclopramide. So it depends where you are, which medications are commonly used. But with all of these medications, where they are used, women will often have to be on them for quite some time. And when they come off, they need to come off them gradually. It can take, with this process of using a galactagogue to increase prolactin levels, it will take as little as a week to several weeks before milk is seen, and the milk supply builds slowly. The second group of medications that are used are hormonal protocols. So these hormonal protocols have been around since at least the 1980s, so a long time. There's a whole variety of them. They attempt to mimic estrogen and progesterone levels that occur during pregnancy to develop the breast for lactation. While estrogen and progesterone are being taken, no milk is made, so it's just working on developing the breast like happens during pregnancy. And these medications are often taken for weeks to months. But then once they're removed, so once estrogen and progesterone are stopped, then the production of milk comes in quite quickly, so within days. So they're different medications. There's also different sort of processes and experiences with these. And the photograph on the right, the Newman-Goldfarb protocol, that's the one that you'll probably find the most information about on the internet. There's a variety of different ones. Yeah, it's one of the more popular ones at the moment. So which medication approach works best? Well, the first thing I would say is more drugs doesn't necessarily mean more milk. So it's not a case that if women go, okay, I want to give myself the best chance of making the most milk, and therefore I'll go heaviest with the most drugs, and I'll do the hormonal protocol, and that's not necessarily the case. Different women definitely have different preferences around medications. So some women are really averse to medications. They don't want to take very much. That's totally fine. They don't need to. Other women find that taking medications gives them confidence, and actually the process of relactation and induced lactation is mainly about confidence, women believing that they can do it. And so sometimes if medication helps provide them with confidence, then that's a great thing. Some medications will be contraindicated for women for a variety of reasons, and women shouldn't feel that if they can't take a medication that means that they won't be able to be successful in relactation. I would say though that if the woman has the care of the infant, it doesn't really make sense to use an hormonal protocol that would delay milk making. Much better to just get going with relactation and induced lactation with a galactagogue or without a galactagogue. But not using a hormonal protocol. I'm just sharing a paper, and this is really an old paper now. It's 20 years old, but looking at the literature at the time on what constituted or what sort of processes resulted in greater or lesser success in terms of milk making for adoptive breastfeeding. And what I found when I reviewed the literature, and I don't think that really anything has changed since then, was that women in low and middle income countries were better at making milk than those in wealthy countries. And I speculate that this is most likely not because their breasts work better, but, and it certainly wasn't because they had more access to medications, or less access to medications. It's most likely because of cultural beliefs around infant care that impeded breastfeeding in the West. So it really is anything that the bottom line to that is anything that can be done to increase breastfeeding frequency and milk removal is going to be very positive in terms of milk production in relactation and induced lactation. So as I just said, the most important factors for relactation success, excuse me, the mother's motivation and confidence, and the frequency of breastfeeding. So we talk about supplementation. So supplementation may be necessary for some time for women. This can be done via a bottle, using a cup or a spoon, or at the breast supply line or drip drop method. At the breast supplementation is preferable as it provides breast stimulation and maximises milk removal. And supplementing milk can be previously expressed breast milk, donor milk, or infant formula. The photograph here on the left is actually a photo of a woman in Afghanistan who's relactating to breastfeed her grandchild because her daughter had died. So you can see there she's using a feeding tube just sitting into a cup of milk to provide that supplemental net. And this is a very helpful poster that's been produced by Lactation International that shows the drip drop method of providing supplemental breast milk to children at the breast. So it's very low tech, but extremely effective. And looking for more information on using a supplemental supply line system, I really recommend this booklet that's produced by Marta Gorth-Gomberger on how to use a supplemental nursing system, so a particular brand of breastfeeding supply line. She describes in there how to use it with a view that it's temporary, so that when the mother's milk supply has increased, the baby is still willing to breastfeed without the breastfeeding supplementer in place. So I mentioned that sometimes babies are very willing to breastfeed and easily. to come back to the breast and others are not. But it's not, it can be very difficult if the baby is not used to breastfeeding. So while the actual process of relactation and induced lactation is simple, sometimes getting the baby to the breast is the tricky part. So attempting breastfeeding when the baby is not hungry, but may be sleepy, maximising skin-to-skin contact can help, and also trying baby-led attachment. And, we talk about the breast crawl with newborn babies. Babies can maintain that instinctive breastfeeding seeking behaviour sometimes for months after birth. And so, that skin to skin can sometimes be very helpful. The other thing that can be done, and this is particularly with an older baby who's been used to breastfeeding, is to slowly make bottle feeds as much like breastfeeding as possible. So that can involve things like holding, if the baby is used to bottle feeding, holding the baby with the bottle so the bottle is going in from a different angle, more like a breastfeeding angle. Sometimes mothers will actually hold the bottle under their arms while they're feeding, sort of under their armpit, using a short bottle. You can see here this mother is using a supply line, and she's actually got the tube fed through the side of a bottle teat that's sitting over her nipple. And so that's a step towards the baby actually being willing to feed directly at the breast. The other thing that can be done is to be around breastfeeding, so the baby sees breastfeeding, not accepting initial rejections of breastfeeding. And I think particularly with older babies, and particularly say it's an adoptive situation or a foster care situation, and the child has been newly placed with the woman, they don't know her, they don't trust her. There needs to be time for the relationship to develop enough for the baby then to actually be willing to breastfeed. So that relationship development process takes time, and so breastfeeding can also take time for that reasons. But it's really important to be persistent and not ever attempt to force the baby to breastfeed. So I'm just going to give some case studies. This one is about relactation in hospitals and clinics that I'm starting with. So this is actually from the Philippines. So you can see this baby had been brought in to the hospital, not doing well at all. Quite malnourished, had been very sick. And then they were supported by the staff at the hospital in the process of relactation. And you can see that they're at 7 months old. So within 2 months, you've gone from a malnourished, very sick baby to a baby who's looking, chubby and happy and doing well and breastfeeding well. This is a case study from a published paper in India. And you can download this and read this for yourself, but just to give a summary. They had 140 infants less than 6 months old in the study who had diarrhea, respiratory tract infections or malnutrition. All mothers had stopped breastfeeding for more than 10 days and weren't able to express any breast milk. The mothers suckled the babies 10 to 12 times a day with supplemental milk dripped at the breast, so that drip drop method that I talked about earlier. And then babies couple spoon-fed additional milk after breastfeeds. The mothers were given assistance with attachment, told to sleep with the baby, give skin to skin and throw out bottles. They were provided with lots of encouragement to build confidence. And it was between 5 and 15 days before they saw breast milk being produced. 83% of the mothers successfully relactated and 61% could stop all supplements. And those who could stop all supplements included a mother with twins and 2 adoptive mothers. So, this sort of at-scale institutional support for relactation, induced lactation, this should be happening in all hospitals all around the world where babies come in with infections. Relactation and induced lactation is often used in emergencies, and so just presenting this case history here. So this was a Rohingya refugee mother in a refugee camp in Bangladesh. She was very ill when she had her baby. Only weighed 23 or 24 kilos herself. She had tuberculosis. When her baby was born, the baby only weighed 700 grams. they knew that this baby was not going to survive if they weren't being breastfed, but the mother was too ill to be able to breastfeed. So what they did in this situation was that they found another mother to act as a wet nurse, and the wet nurse breastfed the baby for a couple of months while the mother was treated for tuberculosis and given additional food. And then once the mother was well enough, they began the process of relactation. So the mother would breastfeed the baby, and then the wet nurse would breastfeed the baby, and then the mother would breastfeed the baby, and the wet nurse would breastfeed the baby. And over a period of a month, the mother was able to relactate and then exclusively breastfeed her baby. And the side effect of this was actually the wet nurse and the mother became really good friends as well. So this was a supportive situation where women were helping one another, and relactation and wet nursing often go quite well together in emergencies. I just wanted to share this as well. This is a brand new guidance on supporting wet nursing in emergencies. It's just been published by UNICEF. So some really useful information and thinking about how wet nursing can be applied. And just another couple of papers of myself actually on wet nursing, because very often in the situation that I described, the case study I just described then, it was the mother who was relactating. But as in the case earlier in my presentation where it was the grandmother who was relactating, you know, if the mother is not available, you know, perhaps she has died, perhaps she's been severely injured and not able to breastfeed. Very often it is a grandmother or a sister of the mother or somebody else who actually takes on that role of caring for the baby, and they're supported to relactate or induce lactation so that they can wet nurse that baby. I also wanted to emphasise, and I know this is something that you're going to be talking about with other speakers in more detail, but there's more to breastfeeding than just the giving of milk. These are a couple of papers that I've written, one from quite some time ago, actually talking about the value of breastfeeding in terms of building relationships in adoptive breastfeeding situations, and a second paper that was only published last year that's actually talking about how breastfeeding again can really support mothers in developing the skills to provide sensitive care to their babies. It really focuses on women who may have difficulty in providing this care because they have experienced abuse or neglect. But I would equally say that situations of fostering or adoption are also situations where women should be seen as being vulnerable and needing support sometimes in developing the relationship with the child, and breastfeeding can be very helpful there as well. Just to put on record, I have personal experience of this. So I've got 3 children. The first one I gave birth to, and the second 2 are both adopted, and I breastfed both of my daughters. And so I have this personal experience of relactation and adoptive breastfeeding. I've got lists here of papers that are relevant to this subject. There's quite a few. And there's my contact details there. I'm very happy if anybody wants to contact me. There's my email address. And I hope that this has been beneficial and that the rest of the conference goes very well. Thank you very much.
Thank you very much, Dr. Carleen. I hope when you listen to the recording of the webinar, you see that you have given us a very informative review of the protocols and how it works, and it really relates much to what Dr. Zahra has previously said, that there are so many protocols and they are different from researcher to researcher. And I hope the audience can get to see Dr. Carleen's email if they have any questions for her. Now we have our next speaker, Dr. Safinez. She's going to navigate with us how it is, how the practices and how the perceptions are in a Muslim country. Dr. Safinez Salama. She is a senior neonatologist, consultant neonatologist in the intensive care unit, Saudi Arabia. She's an international board certified lactation consultant 2016. She's a trainer in the breastfeeding courses of the WHO and UNICEF, the 20 hours and the 40 hours courses. Also the 90 hours courses preparing for the lactation, for the International Board of Lactation Consultant exams. She's a co-founder and board member of the Breastfeeding Association of Saudi Arabia and head of the Scientific and Training Committee, and rightly so. Baby Friendly Hospital Assessor also. She's a member of the Academy of Breastfeeding Medicine, and she's a neonatal resuscitation program instructor, and she is the lead instructor for the American program Stable for Newborns. Welcome, Dr. Safinez.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa rahmatullahi wa barakatuh.
So, thank you very much, Dr. Amal, for this nice introduction. And actually, I'd like to start by thanking ELCA, represented by Dr. Amal Al-Tawil, a very known figure from this field, for inviting me and giving me this opportunity to participate in such an invaluable scientific webinar. So, let me just share with you my screen. Share my screen. So, can you see my slides?
Yes.
So finally we solved that problem, alhamdulillah.
Alhamdulillah.
Yeah, okay. So adoptive nursing perception practices and policies in Muslim world. And these are my objectives to be able to explain or understand the starting with nursing and adoptive nursing in general, breastfeeding kinship in Islam, and adopt the relation between adoptive nursing and sponsoring orphans, and we need to understand the principles behind adoptive nursing, and then we are going through some policies of some of the Muslim countries. To start with, in history, with nursing or cross nursing or nursing another the child of another woman or breastfeeding a non-biological child is actually a common practice for thousands of years before even Islamic era. It was known for ancient Arabs to search and be meticulous in choosing an alternative with nurse. And they believed since that time that children acquire the characteristics of the substitute with nurse for sure. Because it was common for urban families to send their children to the desert to be breastfed, not only to be raised in a pure, healthy environment, but also to be brave and strong, and to acquire fluency, of course, in classic Arabic language. We know that our Prophet Muhammad sallallahu alaihi wasallam, peace be upon him, was initially breastfed by his own mother, as Sayyida Amina, then by the lady Thuwayba for a short time, till sent to the desert and breastfed and raised by Lady Halima As-Sa'diyah. So, and after that, it continued to the same, and in a relatively new era, it is still not uncommon practice among families and neighbors. It is also encouraged in case of mother's clinical or social concern, or if she is unable to feed her baby, sometimes can reach few days or weeks, still much better than giving him a formula, or also in case of clinic or social concerns. As mentioned in Al-Quran, وَإِن تَعَسَرْتُمْ فَسَتُرْضِعُ لَهُ أُخْرَى. And what this means, what said in Quran Kareem, Surah Al-Talaq, which means a divorce, if you find yourselves in difficulties, let another woman breastfeed the child, and that is paid by the father. So now we move to adoptive nursing. Adoptive nursing, or breastfeeding for the purpose of adoption. Adoptive nursing can be by with nursing if the lady is breastfeeding already another child and she's adopting another baby, or can be by relactation if she used to breastfeed before, or by induced lactation, as beautifully explained in the previous two sessions, by stimulating the milk production using hormones, medications, frequent breastfeeding and stimulation, but as mentioned in the protocols we just mentioned by previous speakers. In Muslim societies, adoptive nursing helps establish a legal breastfeeding kinship, making the child legally part of the family under Islamic law. So, induced lactation is the process of stimulating milk production by a woman who has recently given birth or often to breastfeed an adopted baby, or she did not breastfeed before, she not get pregnant before. But the purpose here is to establish milk kinship. So, what we mean by milk kinship? Breastfeeding kinship means creation of mahram relationship. This means a permanent, non-marriageable relationship if certain conditions were fulfilled. What are these certain conditions? The child has to be below 2 years, and most of the scholars referring to what Sayyidina Muhammad said, 5 satisfying separate feelings from the same lady. So if these conditions are met, the child becomes a mahram to that nursing woman and her immediate family. We mean her daughters, her sisters. So a mahram in Islam is a man who is permanently forbidden to marry that woman. A woman does not need to wear hijab in front of him. She can travel with, she can stay alone with, she can sit with, and she without violating Islamic rules. So, mahram in Islam, mahram status in Islam can be by marriage, can be by lineage or blood or giving birth, or can be also by breastfeeding. In marriage, after she is married to her husband, so father-in-law is again also her mahram, stepson, son-in-law, and husband of her mother or stepfather. By blood or lineage, father and grandfather, either maternal or paternal, son and grandson, a brother, either full or half, nephew, and also uncles. These are also her mahram. By breastfeeding, as Prophet Muhammad said, sallallahu alaihi wasallam, breastfeeding prohibits what's prohibited by lineage. يحرم من الرضاع ما يحرم من النسب. And another hadith, breastfeeding prohibits what birth prohibits. الرضاعة تحرم ما تحرم الولادة. So son, through breastfeeding, who is any male who was breastfed before 2 years of age 5 times, and father of that, his father is the husband of that lady who breastfed him. And if she is also a girl, if the infant is a girl, she has brothers from the same lady or same father, that's also her mahram. And also if she has uncle, that there's also her mahram. And referring to Al-Quran al-Kareem, referring to Holy Quran, very clearly mentioned it's prohibited for you, speaking to men, to marry your mothers and also some other group of ladies, sisters, aunties, until it comes to your mothers who breastfed you and your foster sisters, those sisters who was breastfed by the same lady. So after looking at the Islam view of the breast milk kinship, let us go and highlight the adoptive nursing and relation to sponsoring orphans in Islamic countries. Infants adoption and versus sponsorship, as Dr. Zahra beautifully mentioned, that in Islam, formal adoption, as understood in the Western legal systems, is not permitted. And instead, a system of sponsorship and then guardianship أو الكفالة ثم الوصاية is practiced. This is highly encouraged for orphans or abandoned children, and we call it كفالة. Orphans كفالة, كفالة الأيتام أو كفالة اليتيم. كفالة or sponsorship involves providing the orphan financially, emotionally, full support without altering the child's legal parentage. or changing his name. Again, referring to Al-Quran, the highest, I mean, referenced in Islam, showing us how much the virtue of caring for orphans. Worship Allah and associate nothing with Him, and be kind to parents, parents, relatives, and then comes orphans. وبالوالدين إحسانا وبذي القربى واليتامى. So Islam really encourages, strongly encourages the sponsorship of orphans to be with Prophet in paradise as it brings great rewards. And Sayyidina Muhammad said, أنا وكافل اليتيم في الجنة كهاتين. In English, I, the Prophet said, and the one who takes care of an orphan will be in paradise like this. And he held his index and middle fingers for illustration. So it's one of the greatest acts of worshipping Allah Almighty. It reinforces Islamic values such as social solidarity and compassion. Sponsoring orphan should receive, and the sponsored orphan should receive full love and attention, feel safe and secure, and have equal opportunities with other children for upbringing and education. And sponsoring orphans and raising them to be an effective, productive part of them or part of member of the community helps in building a strong society and decrease rate of crime, of course. So after understanding the I hope adoptive nursing and the relation to sponsoring orphans, we need to know what's the principle behind adoptive nursing. We just heard from Dr. Carlin indications of adoptive nursing, different indications of relactation. But here in Islamic countries, mainly relactation and induced lactation are because of adoption. It's breastfeeding, adoptive nursing, what you call adoptive nursing. Breastfeeding, because breastfeeding helps foster emotional well being and a sense of belonging. Very important to feel belong to this family. The sense of belonging of the orphan and strengthening the bonds with the adoptive family. And sponsored orphans should be loved, integrated into formal daily life of that family forever. Adoption is love, not only during early childhood, not only during the period of nursing, first 2 years, not only during childhood when he just come crying, hugging his mother, but also when he gets older. When he gets older, very important to this relationship to continue. If not breastfed, imagine he starts watching mother start as wearing hijab. Sisters no longer sitting with him. He's not accompanying them anywhere. He feels not welcomed at that home. It happens, really, believe me, it happens. So orphan really should be in this integrate into the family for life. Not after reaching puberty, he feels isolated, he feels the stranger, repelled when he grows up, either if it's girl or boy, if not breastfed. That's really a psychological trauma. Believe me, that's happening. Last week, we have in social media here, I'm not sure if you noticed that in Egypt or no, social media showing a boy or an adult. He was taken by a family, adopted at the age of 2 years, and he remained with them till the age of 17 years. At that time, he just suddenly knew that this is not his mother, that is not his father, and he left the house. He left the house at the age of 17 years. That is really a psychological trauma. That is really قهر لليتيم, and is not allowed also in Islam. In referring back to Quran, فَأَمَّا الْيَتِيمَ فَلَا تَقْهَرْ. As for the orphan, do not oppress them. Either take him fully for life or don't take him. So to be taken for life or not to take him from the start. So the principle behind adoptive nursing in Muslim countries is to establish a permanent milk kinship, creating a permanent non-marriageable relationship. Mother is mother. Mother who breastfed the child becomes the milk mother. Her husband, his milk father. Parents, biological children are his milk siblings. So he can remain in that family for life. He can remain with that family, travel with them, stay with them for life, taking care in that house for a home for life. So going and looking at the policies and documentation in different countries. So for that reason, with nursing, adoptive nursing has to be documented. Has to be documented. Not to just to remember to depend on memory, not to depend on memory. Of course, adoptive nursing will be remembered because she took him with purpose. She breastfeed him for purpose. But how about with nurses, which was common in some, more common in some of the countries still? So has to be documented. Everything has to be documented, and documentation of adoptive or with nursing in Islamic countries is critically important to prevent accidental future marriage between mixed siblings or another kind of mahram. I went to look at the many countries actually, east to west, north to south, were Muslim countries, so Muslim society in different countries, and I found prevalence of wet nursing varies actually based on cultural practices, healthcare systems, and national policies. But what's really, I found that milk kinship is legally accepted after adoptive nursing or after lactation or after induced lactation in Muslim countries. So Israel accept milk kinship with induced lactation. An example for that, Dar al-Ifta al-Misriya in Egypt, al-Ifta Council. Al-Ifta is the giving the decision as regarding religious decision, and the same from Malaysia, Fatwa Authority in Malaysia, and in my country, Council of Senior Scholars, هي هيئة كبار العلماء in Saudi Arabia. Examples of those, they consider breastfeeding after induced lactation to fulfill the criteria of uh, milk kinship if 5 feedings and also the age is below 2 years. But the policies and procedures of documentation vary between different countries. Examples of some of the countries in Egypt, Al Habiba, cross feeding and wet nursing is still common in some areas of Egypt, but no national registry for milk kinship documentation. Families may document milk kinship through writing or verbal declarations, especially in rural areas. And in Sharia court or Islamic law court accepts witness testimony to establish milk kinship. Indonesia, for example, no national registry for documentation of with nursing or induced lactation, and documentation is often recorded with local religious offices. So that is optional for the family. With nursing in Turkey is not common actually. With nursing or induced lactation is not common, but there is no official also national documentary system, and families may record or remember such relationship, and they bear the responsibility for tracking milk kinship in areas where it is still practiced. In Malaysia, it's a bit more encouraging, moderate, because they have moderately common, especially among those practicing induced lactation for adopted children, as we just beautifully heard from Dr. Zahra. The Malaysian National Fatwa Council supports documentation of milk kinship to avoid accidental marriage in the future. The Islamic Sharia Malaysia recognized milk kinship again as other countries, and documentation includes recording the nursing records, parental consent, and acknowledgement of that they acknowledge the mahram status. Looking at the Arab Gulf countries other than Saudi Arabia, Bahrain, Kuwait, Oman, Qatar, and Emirates, there is no routine documentation mechanism. Breastfeeding can be documented through the Sharia court or competent authorities, thus also by the families. So in conclusion, and then we look at the challenges. In conclusion, as I mentioned, recognition of breastfeeding after induced lactation as a mean of providing mahram status, that is also available, is well recognized, but there is still lack of centralized registry system across most of the countries. But in Saudi Arabia, the story is different. I'm going to mention it now in the next few slides. Breastfeeding is not mandatory in all Muslim countries for adopting an infant, but the story is different in Saudi Arabia. It is mandatory. It is required to establish family ties under Islamic law when adopting through official channels. So the challenges, I'm sorry for this. So the challenges could be due to legal variations, no unified system for documentation. There is sometimes limited access to authorized courts or religious offices. There may be in some areas lack of awareness that the need for documentation, or sometimes in some families it is just culturally sensitive and they don't like to declare that breastfeeding. Or maybe the challenge behind decrease in some areas the success of induced lactation is the limitation of medical access. So the experience in my country, Saudi Arabia, the experience in breastfeeding is mandatory for adopting an orphan or an infant, for, or more accurately, to use fostering other than adoption, especially foundlings. I will those so unknown parents. This creates mahram status between the foster child and the family, and provides a normal life for the child within the foster family, so that physical closeness and living arrangements are permissible in Islamic rules for life. The orphan, whether male or female, will not be forced to isolate himself or herself from certain family member after reaching puberty. So in Saudi Arabia, the normal channels or the official channels is the of sponsoring an orphan is through Al Widad Orphan Care Association. This association is authorized by the Human Resources and Social Development, the Ministry of Human Resources and Social Development, authorized to be responsible for all orphans under the age of 2 years. So they provide the service of receiving orphans, providing them with care, and then assigning them to qualified families after ensuring they meet the adoption or fostering requirements. What are these requirements? They set few requirements, and also these requirements are agreed on by the ministry and by the Hayat Kibar al-Ulama or scholars. The criteria or the eligibility criteria, the family has to be Saudi, they have to be married couple, they don't accept single mother, the applicant must be at least 25 years old, not more than 50. Also, they have to pass medical examination to be sure that they are free of infectious diseases with no criminal records, and also they must be no pending application previously. If they have an application rejected, they have to wait for 1 year after that, and they have to pass the assessment of social, and to be sure that they are suitable family regarding social issue, psychologically stable, and even economically stable, so to be sure that they can take care of that child. If they have children at home, they are below 6 years of age, should not be more than three, and the breastfeeding requirement for the child is a must. If not by the lady herself, or failed induced lactation, can be by other lady of the family with an agreement by Al Widad. And then they have to successfully complete a training course given by the same association. Then they are going to apply for that for the sponsorship, including, and they have to include their photos, national address, educational qualifications, marriage contract, salary statement, and also prove that they have residence. So the program was set by Al Widad and approved by the ministry and approved by Hayat Kibar al Ulama or Council of Senior Scholars. And they received a full in details fatwa mentioning will be the mahram, if the lady herself who breastfeed, or her sister, or her daughter-in-law, or the auntie or the sister of the husband. So beautifully mentioned that the advisory opinion states that if a child is breastfed 5 times below 2 years, he can be he can belong to that family. And in that detailed statement mentioning, if not the lady herself, who else can breastfeed to stay with that family. So breastfeeding of an adopted infant is a must in our country. Is really a must. And Al Widad is not a medical society. And for the program of induced lactation or relactation, they have cooperation agreement with breastfeeding associations in Saudi Arabia. One of these, with the breastfeeding association, it's under renewal currently with the تعزيز الرضاعة حاليا, and to help the family for induced lactation. And the breastfeeding documentation also is a must, and it has been in the وزارة العدل or Ministry of Justice. This is carried out in cooperation between Al-Widad and Ministry of Justice. Documentation of breastfeeding confirm the legal relationship of the foster child. Actually, if not an orphan or somebody who breastfeed another child, they can also apply documentation through Ministry of Justice. And application for documentation used to be through NAGI's platform online, but currently this and online documentation is under review. NAGIS is a electronic platform belongs to Ministry of Justice. If you are interested to look at it, this is the how to reach it. And NAGIS in Arabic word is an Arabic word means completed or accomplished. And by this slide, I also completed my talk. And let me just finish by showing you this beautiful fountain at the Red Sea, Jeddah, my city. And thank you very much.
Thank you very much, Dr. Safinez. We really got some good ideas about how to document breastfeeding and milk kinship. This is really very interesting, and I think Muslim countries need to collaborate on that and try to unify a mechanism to document milk kinship and legalize it.
Yeah, actually, very important. Yes,
Yeah,
very important.
yeah, because other foster care is not really a good alternative.
Yeah, fostering without being belonging to that family for life. It's not just to satisfy the lady or the parents or the couple for the first for 2 years or few years. How
Yes,
about the right of the child himself?
yes,
To
and
maintain the right of the child himself, he has to feel secure in that home.
yes, and also the the orphanages are not really a good alternative. I think Dr. Carlin has also worked on children in orphanages and the psychological trauma that they have
Yes.
when they grow up, and they need always to find their families. But milk kinship will offer a solution for such
Yes.
position.
Yeah, هذه من نعم الله actually. Yeah, and he has the right to feel secure. How
Yeah.
about taking an orphan just to satisfy myself for a few months or few years, and then he has to one day he will leave that home. No, he
Yeah.
has to feel secure. He has
Yes.
to be secure for life.
Yes. Yeah. Thank you. Thank you so much,
Thank you
Dr.
very much.
Safinez.
Thank you very much. Thank you very much, Doctor.
Anyone has questions for Dr. Safinez?
Yes, please, Dr. Amal.
تفضل.
Thank you very much for this amazing day. Thank you, Dr. Safi, for the really very interested topic. And if you don't mind, I have two questions. The first one is how to know this amount is sufficient feed for the baby below 2 years to be sure this is يعني the fatwa according to the fatwa.
Yeah, okay. So if you read about the fatwa, it's mentioned if that they mentioned very clearly. If you go in details to read about the what scholar said, if the child is fed and he left the breast by himself, that is we consider it one. If even if after he left the one breast and then he start to feed from other breast, they consider that the first one is separate. This one and the second is another one. So that if you go to details, actually احنا we are not allowed to give fatwa, but this is what I read. But if you read in fatwa, they describe how they count those five.
Okay.
Written by the scholarship or those who are they have the right to give fatwa. They wrote if the child left the breast, you consider it that finished first. If he again breastfeed from the second one, and sometimes أعتقد دكتور سماح صح؟
انا سماح يا فندم.
طبعا عرفت الصوت الجميل. And also they mentioned انه can be not direct breastfeeding, can be by expressed milk, not necessary to be direct breastfeeding. If breast relactation or induced lactation, mother produce certain amount of milk and satisfy the child, can be through express. So if you're going to read into fatwa, you're going to find description of the how to know the child is satisfied, means that the baby is satisfied. The
Okay.
full feed, I mean, or you consider it finished one, satisfying the baby.
Okay, okay. My second question for you and for Dr. Amal also, if the mother, she will adopt a baby girl, once
Yeah.
this girl will reach, for example, 16 or 17 years, it will be also a mahram for the husband of this
Yes,
mother?
yes, because they, even in the fatwa, I just show you in the on the Arabic letters, it's
Yeah,
written, it's considered من الربائب وربائبكم اللاتي في حجوركم. They
noted.
consider him من الربائب.
Okay,
Hmm.
okay. We also allowed to tell the mother, the adopted mother, this fatwa, Dr. Safi, right?
طبعا هذا الموضوع عن طريق جمعية الوداد, through the الوداد association. They show them everything. They have to understand, because in case she did not succeed in the program of induced lactation, they will give her the other option. She has auntie, إذا في auntie مثلا أخت الزوج هي اللي رضعت، صار الزوج هذا خالها.
Hmm.
لكن لو عندها أولاد حيكون في مشكلة، حيكون أولاد خالها في البيت. يعني كل أسرة every single family will be dealt with separately in case the mother did not succeed in that program. Sometimes she did not succeed in program of induced lactation.
True.
So they will take every family separately and give her the other option.
True. Thank you, Dr. Safi. Thank you very much, really.
الله يسعدك. شكرا. Thank you. So I'll stop here sharing.
السلام عليكم دكتورة أمل، دكتورة صافي.
يا هلا وسهلا.
عندي سؤال.
السلام دكتورة
أهلا
أسماء.
حضرتك.
عندك سؤال يا دكتورة أسماء للدكتورة صافي؟
بعد إذن حضرتك.
اتفضلي.
It's not يعني a discussion or a comment more than a question, because here we have WIDAD facilities also, and I face some problems with parents coming to my clinic or facility. We have a facility that supports adoptive families, and they would like to have a certificate from our facility that they already fed the baby, or else the dad wouldn't have handed over the babies to them, because they say in the facility of the Widad, they said we are already gave him 5 breastfeeding, but actually what happens on the ground is the baby latches on the breast and he's just calmed by sucking at the breast, but there's no milk. When the mom comes and I put the pump, there's no one single drop of milk, and they fight for, they can't have the certificate from Al Azhar unless I or any other doctor give them this certificate from a facility, medical facility, that they breastfed, and they're coming to my facility asking for this certificate. But how can I witness something that I didn't see? So we have this conflict. Like, if it is just related to satisfying the baby at the breast, it might be a satisfaction of calmness, like soother, like a theta pacifier. So how do you sort this out? Because the branch of Wodad in Egypt, it's one among many and many other orphanages, but this specific facility here, at the time, they won't hand over the babies unless they had the 5. According to the workers in the Wodad, this lady breastfed the baby. But actually, there's no milk. She didn't even start the lactation process, and she comes, please doctor, write me a certificate to take it to the Azhar. When I put the pump, when I do manual expression, there's no single drop of milk coming. And they are persistent. Actually, they're fighting for that. How do you sort this out?
Actually,
This
this is
is
a very important point I would like also to raise. Maybe the baby will leave the breast because he feel frustrated. There is no milk, and he will leave the breast.
Not satisfied.
I
Or
think
satisfied because of the hugging process.
no, I
Not
think
because
what's meant by satisfaction by milk, not only
yes, this should
satisfied.
be highlighted when we tell it
No,
to the public, because they come and they're eager. Please write me a certificate. How can I write a certificate for something that I haven't seen?
That's why
So
Al Widad
we
has
should
a
write.
cooperation, signed a cooperation with the breastfeeding associations. We have breastfeeding associations we have تعزيز الرضاعة, we have breastfeeding association. I mean, that's why they have a cooperation with these associations with, and they have lactation consultants. And Widad herself is not a medical, they don't have medical members, they don't have lactation consultant. So I think that part is taken by the lactation consultant of the breastfeeding associations. But
should
what I
highlight
understand,
inspection, not
satisfied
calming
by
down.
feeding, not satisfied by just calmness or skin to skin contact or just suckling an empty breast. I think it's
Thank you.
satisfied by milk.
Yes, we should
Hmm.
highlight it because it makes a lot of trouble. They
No,
come like
I don't think
the
that
mother swears to God that I
I don't think
breastfed him, but she's not convinced.
No, I think the
But
lady will be keen just to hear to tell you he's satisfied. But I think it has to be, it's a very big responsibility of the one
Exactly.
who is dealing with the mother in the program of induced lactation, and it should be really taken very seriously, and not to sign unless he is sure that maybe mother has milk and really
For
satisfied,
us, we
not
have some
satisfied.
regulations I might tell in my lecture later. When the facility writes this certificate for the parents to take it to the Azhar,
Hmm.
we should see, we have some specifications I would
You're
mention in the
right.
lecture later,
You're right.
inshallah.
It's really a big responsibility. You're right.
Yes, it is. So I just want to modify the terms of the WDAD, at least here, because they're so that sure that you're a cruel doctor because you're not giving me the certificate. But I can't give them according to the WDAD.
yeah,
Actually, al-fatwa written in details.
Yes,
Al-fatwa written in details. If we go through it, written in details. What do you mean by satisfaction? It's
thank
not
you. Thank you
just
so much.
yeah. So it will be taken seriously. You're right. Thank you.
Thank you so much. Grateful, Dr. Safinas. Thank you.
Thank you. Thank you.
Pleasure known.
I think it's a matter of ethics. You cannot, you just tell them, I cannot sign something that I didn't witness.
Yes, and this happens, but they feel like we are the cruel doctors who are forbidding them from having the
Okay,
certificate. But
but
I have to be
this
cruel.
is
I have
this
to.
is a legal
I
witness.
know.
What
Yeah.
your position is a legal and
Yes.
a
صحيح.
legal witness and a
شهادة.
legal responsibility.
شهادة فرصة صادقة. هم بيكونوا في stress.
Thank
They're in stress. But it is also responsibility for
based
them.
on what they have been told in the WDAD. That's what made them like fight for fiercely for the certificate. But I'm sorry, I can't witness something that other
You're right.
stated.
Yes, right.
Thank you
Yeah.
so much, Dr. Saf. Thank you so
Thank
much.
you. Thank you.
Now we come to Professor Rani Al Faraj. She's going to tell us about how is there an interplay between the biological part and the emotional part. Dr. Rani Al Faraj she works as a professor of pediatrics and neonatology. She's a consultant at Children's Hospital Ain Shams University. Cairo, Egypt. She is a coordinator for Baby Friendly Hospital Initiative at Ain Shams University. She's Egypt's representative at the International Council for Respiratory Care, and she is the International Fellow of American Association of Respiratory Care. Dr. Rania is the General Secretary and one of the founders of Ain Shams Society for Neonatal Care and CME, Clinical Fellowship and Great Ormond Street Hospital, 2023-2024 at UK. She's a neonatal life support instructor since 2019, neonatal resuscitation program instructor since 2020, and simulation full instructor awarded by Mobile Pediatric Simulation Team 2017. Dr. Rania also has many international publications with 318 citations and H index 11. She wrote Neonatal Pulmonary Disorder chapter in Walsh BK editor, Neonatal and Pediatric Respiratory Care, 4th edition, 2015, St. Louis, published by Elsevier, 2014. She won many academic prizes, including Ain Shams University International Publication Prizes yearly from 2011 to 2021. She has maintained this for 10 successive years. The Academy of Scientific Research and Technology Award in the field of medicine, Professor Dr. Yahya Al-Gamal Prize 2017 and 2018, and State Encouragement Award in the field of medicine 2013-2014, awarded by the Academy of Scientific Research and Technology for academic achievement. In clinical research and international academia, as well as in medical education and clinical care. Welcome, Dr. Rania.
Thank you, Dr. Amal, for such an honorable invitation. I really enjoyed such meeting with my colleagues and even my family. I feel it's like you are my second family. So I'll share my presentation here. So good evening, everyone. My name is Rania, and today we will explore the complex interplay between biology, psychology, and epigenetics in the remarkable process of induced lactation for non-birth mothers. Breastfeeding extends far beyond nutrition.
Can you mute a full screen, please, Dr. Rania?
It's a full screen.
من slideshow.
Yeah, it's a full screen. You can see it full?
No, we don't see it slideshow.
Okay, just a moment. And this one, okay?
Yes, yes.
Okay, so breastfeeding.
Dr. Rania, you can share the entire screen. You can choose the share screen, entire screen option for us to be seeing your.
Give me a moment again. The entire screen here, you mean? Okay. This works better? Can you see this screen?
Yes, yes.
Yes, Dr. Rania.
Okay. So breastfeeding extending far beyond nutrition, it is a sophisticated biological and psychological process that fundamentally shapes both maternal and infant development. It serves a dynamic communication system between the mother and infant, transmitting immune factors, hormone, and even emotional signals. As we have seen in the previous lectures, induced lactation demonstrates the remarkable adaptability and plasticity of the female body, challenging conventional understanding of the maternal biology. Today, we will cover four keys. First one is the hormonal regulation and physiological adaptation. The second one is the oxytocin release beyond biology. It's important in stress reduction and maternal identity. Its psychological effects and benefits for the child, for attachment formation and nervous system regulation. And the last topic will be the breast milk epigenetically reprogramming aspect of child biology. Breast milk dynamically adapts to infants' needs, including age-specific nutritional requirement, immune status fluctuation, and even during illness episodes. There is an orchestral play or interplay. The two maestros are the prolactin and oxytocin hormone. As we've seen here, and we all know, there is a neuroendocrinal loop that starts by skin-to-skin contact, stimulating a mechanoreceptors at the mother's nipple, ascending action potentials to the hypothalamus here, stimulating the nuclei, releasing hormones, to stimulate the anterior pituitary to release prolactin and the posterior pituitary to release oxytocin. Both of them acting on the alveolus to produce milk, where oxytocin contracts myoepithelial cells, forces milk from the alveoli into the milk duct, which we know as milk letdown reflex. Remarkably, through pharmaceutical and mechanical stimulation, the same hormonal pathway can be activated in adoptive mothers, enable successful induced lactation. There is like a crosstalk, a biological dialogue between the infant signals and the maternal response to adapt into a customized nutrition, providing what exactly the infant needs even in this induced lactation. The second step is the psychological imprinting. Adoptive mothers who induce lactation experience, as we are going to see in the next few slides, the same oxytocin surge as the biological mothers. The oxytocin here is like a story. We are gonna deep digger into what stimulate oxytocin release and what is the action of oxytocin beyond hormonal action. We have four major sensory pathways for oxytocin release, including sucking that activate the mechanoreceptors at the breast, as well in infant sucking activating mechanoreceptors in infant mouth. So oxytocin released into the brain cells, maternal brain cells, maternal systemic circulation, and the infant systemic circulation. Oxytocin have a crosstalk with the parasympathetic system. Oxytocin stimulate vagal sensory nerve and the cholecystokinin in the VGIT, stimulating oxytocin release in a closed loop connection. Also, simple skin-to-skin contact will stimulate the sensory nerve to release oxytocin. So, oxytocin acting to enhance bonding with the infant, improving social responsiveness of the mother. It has an anti-stress effect, as we are going to see. Oxytocin has decreasing blood pressure effect and improving the digestive process. These changes occurs through stimulation of different central nuclei in the amygdala, in the noradrenergic neurons, in the hypothalamus by inhibiting corticotropin releasing factor, also oxytocin increasing inhibitory alpha-2 adrenoreceptors. Again, oxytocin decrease the ACTH release, finally decreasing the cortisol release. All these effects are anti-stress effects. This anti-stress pattern facilitated during skin-to-skin contact, explaining why mothers and newborn, both of them exhibit marked stress reduction during this interaction. This figure comparing the biological mothers and the adoptive mother with induced lactation. Isn't it remarkable that the adoptive mothers can experience the same hormonal surge, especially anti-stress effect with cortisol reduction and oxytocin surge at the biological mother, subhanallah. This graph showing that statistically similar physiological response between the biological mother and adoptive mother with induced lactation. Also, in this illustration, the infant salivary cortisol level measured in biological mother breastfed feeding and adoptive mother with induced lactation with similar reduction in the salivary cortisol compared to adoptive non-breastfeeding mother. So there is marked stress reduction, which is measurable, showing the difference between adoptive breastfeeding mother with induced lactation. So, what is the effect on psychological impact on the mother when oxytocin release with anti-stress effect for mothers, there is decreased anxiety. It fosters confidence and their legitimacy and validation, enhancing emotional bonding, facilitating profound and emotional closeness and attachment, even sustained skin to skin contact with such neurobiological feedback loops. The next is the psychological benefits for the child himself, with a review article published by our colleague who had a talk previously in such webinar, Dr. Carleen Grippel. She demonstrated a neurodevelopmental pathways that is stimulated by oxytocin release. We usually say that the vagus nerve is the nerve for rest and digest. Act of breastfeeding stimulating the vagus nerve, stimulating the parasympathetic tone with the digestive function. Also, eye contact during feeding, activating social brain networks, activating facial recognition pathways, with a trust formation and consistent tuned response from the mother to the baby, including emotional and predictable nature of breastfeeding, helping infant develop self-regulation capability. These neurobiological processes are similarly activated in induced lactation, suggesting the critical elements are not only the hormonal direct biological effect, but has a relational experience and feeding context than that occurs in induced lactation. Also, we said that oxytocin has an anti-stress effect, but on the mothers, in the infants, it has a synergistic combination of mechanisms that lead to calming and analgesic through stimulation of the oral receptors, focusing attention and reducing external distraction, skin to skin, directly stabilizing the vital signs in many published papers, aiding neurobehavioral self-regulation and decreases stress. As we have mentioned before, milk absorption triggering the vagal or parasympathetic cholecystokinin release, which leads to relaxation and pain relief. The natural sweetness of milk stimulates opioid release in the midbrain, decreasing the pain perception. And finally, intimate social engagement between the mother and child, inducing reinforce the anti-stress oxytocin release. These combined effects contribute to an infant overall well-being and development. Also, breast milk have LC-POFs, long-chain polyunsaturated fatty acids, including arachidonic acid and docosahexaenoic acid, which are abundant in breast milk, and they are directly linked to improve neurodevelopmental outcome, better cognitive function, and a higher IQ. As regard epigenetic imprinting, what do we mean by epigenetic imprinting? It is defined as changing in the gene expression without altering the underlying DNA sequence. It's like a tuning. It's like on and off, turning the gene on and off. The key mechanism in this through DNA methylation, histone modification, and microRNAs are the primary ways to epigenetic works. The microRNAs in the breast milk are acting as a molecular messengers, regulating infant gene expression by triggering DNA methyltransferase. Those enzymes are involved in epigenetic modification. This paper published in 2019 in Sciences Advance about the epigenetic dynamics in infancy. They run a dyadic model of behavior, and they prove that changes in the DNA there's changes in the DNA methylation of the oxytocin receptor gene. Here, they summarized their finding that there is a significant association between the quality of maternal engagement or maternal behavior at the age of 5 months and the reduction of the oxytocin methylation from 5 to 18 months. Also, there is microchimerism. During breastfeeding, maternal cells, including powerful stem cells, transfer to infant through milk. These maternal cells integrate into the infant developing tissue, including the brain and the immune system. This creates a long-lasting biological legacy, remains with the child for decades and even throughout life. Imprinting and immune programming. HMOs are complex sugars that is present in the breast milk, promoting healthy gut microbiota in infants. This diverse gut ecosystem will help shape a robust immune phenotype. Through epigenetic modulation, breastfeeding has shown to significantly reduce the risk of common respiratory infection and asthma, various allergies, even immune diseases later in life. Also, breastfeeding has a protective role against chronic diseases such as type 2 diabetes, obesity, cardiovascular diseases through epigenetic modification. Also have a crucial role for regulating metabolism and inflammation. We have a critical window, the first 2 years of life, where this is the peak epigenetic activity, peak DNA imprinting, most active and influential. Also, the crucial development of the metabolic and immune pathway. Maternal benefit. We discussed the child benefit from epigenetics and researchers published papers proving that breast milk through epigenetic remodeling induces favorable epigenetic changes in the mammary stem cells, decreasing breast cancer risk. Also, the hormonal changes and shifts during induced lactation, promoting apoptosis of potential cancer cells and modulating inflammation with a lower incidence of aggressive breast cancer. There is a new highlight or emerging insight about what we call milk sibling epigenetic and transgeneration effect, where recent researchers suggested that breast milk microRNA may transmit epigenetic signals that influence not only the fed infant, but potentially future generation also. And they have experimental models that exploring what we call milk sibling relationship, where multiple offsprings are nourished by the same mother could affect genetic disease risk via shared epigenetic pathways. From this, we can say subhanallah for the implications in Islamic rules that breastfeeding established a kinship bond equivalent to that of blood relation with correspondence implication for social and legal prohibition. الآية الكريمة في سورة النساء حرمت عليكم أمهاتكم إلى أمهاتكم اللاتي أرضعنكم وأخواتكم من الرضاعة. سيدنا محمد عليه الصلاة والسلام said يحرم من الرضاعة ما يحرم من النسب. And in conclusion, there is an emotional biological bridge where lactation is one of the rare biological systems that is both responsive and relations. It speaks to the body, heart, and the soul. Through induced lactation, we see powerful evidence that the motherhood resides not only in the womb, but in the breast, in the arm, in the unwavering intention to love her nature. In every drop of milk, there is more than nourishment. There is cellular dialogue, genetic tuning, and quiet biological miracle where motherhood is written not on the chromosomes, but in contact, compassion, and care. Thank you.
Thank you very much, Dr. Rania. I must admire and admit Dr. Rania for her poetic talents. She has demonstrated that while we were trying to find a good title for her lecture. She proposed like 12 titles, of which we chose this one. And the 12 really made me confused which one to choose, because they were really all very beautiful and very poetic. So thank you, Dr. Rania. And anyone has questions for Dr. Rania? No questions for Dr. Rania?
Okay, thank you, Dr. Aman.
Thank you, Dr. Rania, very much. Now we come to Dr. Asma, and she has some great experience with cases of adoptive nursing or induced lactation for adoption. Dr. Asma is a neonatology consultant and a lactation consultant. She's the founder of Lactate Centers for breastfeeding counseling. She is an MBAS practitioner and LS course director. Dr. Asma is a neonatology consultant who has dedicated over 20 years to caring for newborns and their families since 2004. She combines her expertise in critical care with a deep passion for supporting parents and promoting the psychological well-being of families during and after NICU stays. In 2013, she became an international board certified lactation consultant and founded Lactate Centers, which provide pediatric medical care, lactation support services, antenatal and postnatal parental awareness courses, adoptive families support, alongside training healthcare professionals in lactation medicine practice. Her interest in understanding newborn behavior led her to become the first certified neonatal behavioral assessment practitioner in Egypt, 2022, from Basildon Center in the UK. Dr. Asma is also a member of the Egyptian and European Resuscitation Councils, where she currently serves as course director and instructor trainer for the neonatal life support program. Dr. Asma is going to give us some clinical pearls, learning from the challenging journeys that she has witnessed and helped. تفضلي يا دكتور أسماء.
Thank you so much, Dr. Amal, for giving me such a chance, a beautiful chance to join this webinar. Actually, I've been enjoying listening to the lectures ever since like 2 hours ago for now, and it's all catchy. I couldn't just switch my eyes over the yes, actually, indeed. Thank you for the bouquet of these nice lectures and the lectures. Okay, so this, as you've asked me, is going to be a clinical journey through our cases and as regards adoption or kafala in Egypt. So, is it?
If you can mute yourselves and beware of the screens. If you're opening your cameras accidentally.
Okay. I think the organizer can switch off any cameras if it's open accidentally. So, are we sharing the screen now?
Yes.
I
Yes, we can see your screen.
Okay.
Dr. Asma, can we, before you start, can we mute all, then you unmute yourself.
Okay.
Dr. Fatma, please mute all. Mute all, and if you can switch off the cameras for everyone. Go ahead, Dr. Asma.
Okay. Shall we start now? Can you listen to me?
Yes, but make
Okay.
it
Thank you. So let's start our journey in Kafala, the experience in according to our cases or our families that we follow in Egypt. First, Kafala in Egypt. So this is Egypt. We should highlight that we are very diverse community, a very layered civilization. We have a population of
حضرتك عاملة سلايد شو؟
أيوة مش بيتقلب.
لا. Can you please share the screen for the entire screen, not only the window?
So I will stop sharing.
Stop sharing, then share the screen for the entire screen. Choose the entire screen option.
Entire screen.
Yes.
No. I can see myself and the screen of the Zoom meeting, but not the.
Yeah. Choose the entire screen option there. Yes. Yes.
Yes. Can you
Yes.
see the
Yes.
population?
Perfect. Yes. Perfect.
Okay. So if we are going to talk about the experience of adoption in Egypt or kafala in Egypt, we should know that the population is around 118 million, where Cairo alone has 10 million, births of about 2 million births per year. The number of adoptive families by the year 2025 is 11,800 adoptive families. MashaAllah, the last year were just 390 adopted kids, just the last year, and the peak, the max rate was at 2021, where there were 3,000 adopted kids in Egypt. This is, yes, quite a big number, but it's not a ratio. If you compare it to the whole number of the population, 3,000 kids is a very big number, but not quite a ratio so that people won't get confused or think this is something very frequent. Because unfortunately, these 3,000 kids have specific circumstances that we are going to talk about, which is the challenging part in the adoption in Egypt, because they're left they are kids that we don't know their parents. They are not a known parents kids. So, who choose to adopt in Egypt? It's either a family, a father and mother, and a married couple, or a single unmarried female. The law here allows a single unmarried female with some regulations to adopt a baby or do kafala. They could be parents with no biological kids, usually with history of infertility, and this is the vast majority of our population, or second time adoption. They might be adopting a kid, and then after 2, 3, or 4 years, they come and adopt other kids, and that is a very blessing and successful opportunity to deal with such families, the giving family who adopt once and twice, and or they can be having biological kids already, but wishful helping kids or more thawab, and they're doing it for mere charity. This is the population of adopted families that we meet in our work. Over the last 5 years, awareness increased, parents and single mothers got encouraged, government facilitated the procedure. We have two major NGOs supporting kafala. One of them is kafala in Egypt. The number of orphanages decreased over the last 3 years because the number of adopted families increasing, and this is a very good news and a very cheerful news to share. Adopting families are now put on waiting lists. On the contrary, in the past, there were many kids with no families. Now, all the newborns found families easily, and parents, or inshallah, future parents, are on the waiting list, which is another cheerful piece of information that I'd like to share. Right. If we are talking about our experience where I work, we are blessed to be following around 300 adopted kids and families. This is the bulk of from where our experience came, and that's what I will be sharing here today. We have many great stories, many great journeys. Actually, we are the blessed ones working with such families. Our team is currently in where I work, 7 active doctors and 10 trainees. 6 out of them is pediatrician. 3 are NBES, our NBO practitioner, which is the neonatal behavioral assessment scale or neonatal behavioral observation, and we will get to know why is this important in the teamwork of the working with adopted families. One is MINRI practitioner. MINRI is the motor neuron reflex integration that is meant to work with the oral problems and the muscle problems and neurological problems of the kids. If we are wishing or talking about the induction of lactation for adoptive families. This is my team. Here is a sample of our blessings that we see during the journey. This is how we receive the babies. Many babies, when they come at the first visit, we always advise the parents to bring the baby directly to the center even before they go home, so that we can take the primary measures, the length, the weight, the head circumference. We can have a baseline assessment to the baby. The infant can be 3 months onwards. It's never below 3 months. But when we take the primary measures, we do the primary examination. It's very enlightening and actually blessing and cheerful to see the progress along the next coming 2 months. When we check this graph, for instance, it's the weight for age. You can see how rapidly the baby increases in weight after being adopted and taken home with the new family. This is the length, even the length increase. The weight for length, it's increasing and idealizing, optimizing, and the head circumference. We have plenty, like hundreds of these curves. When we see them, we are just actually think we are the blessed ones seeing those families and those kids and seeing the progress in both the health and the psychology, just like Dr. Rania's explained. So navigating through a journey of our adoptive families in Egypt, it starts with a searching family and a found child. Unfortunately, most of them are found. We don't know their parents. We don't know anything about their past or biological family. So it starts with a searching family and a found child. The newborn stays at the orphanages or the facilities that's according to the family, the Ministry of Social Services, while the family fulfills the requirements. Baby taken home no earlier than 3 months of age, which is the first obstacle we usually face in Egypt. They cannot take the baby earlier than 3 months, which is actually a very big obstacle to us in induction of lactation. So the challenges on the road of induced lactation with kafala, with adoption, starts with having a bottle-fed, formula-fed infant for at least 3 months. Potential parents or mothers can't always visit the infant during these 3 months. The child may be even in other governorate, kilos away, many kilos away from the adopting family. So this is an obstacle. We don't have any medical, social, psychological information of biological mother and family. Maternal age usually above 35 years after multiple trials of unsuccessful IVF. Some ladies have 11 trials. The last week I had a lady with she was 43 and she had 11 trials of IVF. So this is the journey that usually the parents here in Egypt go through, many of them till they decide to have adoption or kafala. Not all, but most. With or without medical issues, some ladies might have diabetes, insulin resistance, autoimmune diseases, menopausal surgeries or oophorectomy, for instance, or even the young ladies might have primary infertility for many reasons. Some might have male factors, and this would be easier for us for induction, but when we face female factors, this is another obstacle in induction of lactation. Okay, the steps is as follows. As soon as the family decides to adopt, they are directed to official social groups, NGOs, and to support peer support groups, and they visit our center to receive the pre-adoption counseling sessions. It is an equivalent of antenatal preparation session. It aims at preparing the families and setting targets. It's sometimes a group of 3 or 4 families together in a group, and they get to know each other. They get to know to go to groups for support groups later, or sometimes it's a one-to-one, like I just sit with the parents, the mother and the father, or the single lady alone to discuss and set plans for what's coming. And it's not about only lactation; it's about the caring of the newborn, the physical and the psychological aspects of adoption. Our targets in this discussion is always set a suitable induction plan according to mother's target and health condition, putting into consideration that we face many health conditions in our population of adoptive mothers. To discuss the emotional and physical needs of adopted infant, because many parents have expectation that we'll have a happy, smiling, and a playful kid, but they are faced with, unfortunately, a traumatized infant, and an infant that averted to touch, averted to being carried, owed to the history that we don't know anything about, either during the pregnancy or at least in the 3 months during staying in orphanages. So they should be prepared emotionally because they might not receive the baby that we're dreaming for. Then avoid or decrease maternal post-adoption depression. And this is something that we've been facing a lot recently, because after the mom gets the baby, with or without the lactation, the induction of lactation, many mothers face post-adoption depression. It's very similar to postnatal depression, so we should prepare her to handle it. Unfortunately, this might reach to the extent that the mother takes the baby back to the orphanage, and this is a very hurting, bad experience to everyone, to the doctor, even to the parents, and to the child for sure. So these are some of the pre-adoption setting that we arrange for. First, set a suitable induction plan. Families have different targets in breastfeeding or induction of lactation. Some just come for 5 feeds for the kinship, the milk kinship. Others aim for more. A suitable induction plan includes the mother health and the time factor, which is a very important part as regards our conditions in adoption or kafala in Egypt. First, the family target of breastfeeding. It can be just 5 feeds for the milk kinship, from 1 to 10 according to their Sharia reference. And here we should state that we are not sheikh, we are not fatwa person, we are doctors. We just help them in what they need. Some people come and say like 1 feed is enough. Others say that the reference needs 10. The usual say 5. But we help them in what they need, and we give the certificate according to what we see later of achievement. Breast milk, bottle feeding as long as possible. Some parents just wish to fill the bottle with breast milk, not direct breastfeeding, and some more enthusiastic or cheerful, or maybe high aiming families aim at direct breastfeeding as long as possible. Many of them, mashallah, reach exclusive direct breastfeeding for up to 1.5 or 2 years, even better than many other non-adoptive families if we compare by the length, not the quality or anything else. So this is a very encouraging miracle, I think. And this is what they get after we give them the certificate from the doctor that they already fed. They go to Amanat al-Fatwa fil Azhar and they have the certificate that this baby is the infant of that lady, and accordingly to that man, the husband, by milk kinship. And this Dr. Safi, I think, explained thoroughly why is this important in Islam. Some second option that or point that we discuss in our sessions, the mother health condition, they are usually above 35, previous IVFs. We discuss if there's any family history of oncological diseases, cardiac problems, hormonal issues. Sometimes we need to do chromosomal analysis, and yani, in 3 of my patients, we discovered that there's some chromosomal problems or aberration for adoptive mother, and that delayed the process of induction of lactation, but did not prevent the process of induction of lactation. As for the time factor, age of infants is important to put while we're discussing our plan. Social condition, is the mom, the adopting mom, working? Is she getting any help? Can she stay at home to pump after she receives the baby? Or we will face problems because she's having the baby and the next day she's going to work. She's not having enough time for pumping. We should ask ourselves, would she be able to pump 6 to 8 times a day with a kid around? And that's why we usually advise them to come early before they have their child at home, because no one can guarantee the time management and the control of the tasks after the baby is at home. So then we put this plan to discuss with the family. To have induction of lactation for this baby, we need to fulfill some points, like fill the puzzle of the lactation. First, we have to increase the milk. Then we have to convince the baby to latch on, and sometimes we have to strengthen the baby's the muscles, the sucking muscles, to be able to directly breastfeed according to the mother's plan or wish. In the aspect of increasing or milk production, I think this is the easiest part. We have many protocols that has been previously discussed with other in other topics in other lectures today. We have the regular with at least with 4 months preparation with oral pulsosepsis pills, accelerated with 1 month, and what we usually do is no pills at all because of the time factor, because of the age, because of the maybe previous history of oncological diseases or whatsoever DVTs. So usually we use no pills. Sometimes we use 1 month preparation, and we rarely do the 4 months or longer preparation. We usually depend on pumping 6 to 8 times, domperidone if the health allows, status allows, and the herbals. Obstacles that we face once the baby is home, we face the commitment to pumping, the visits, the arguing, and the negative comments of the family, and that's why we need a team approach for the family all and the community to convince them to help the parents. We have the aqiqah, the baby shower, as we say, the celebrations, all these, some paperwork that need to be completed even after the baby is at home. These are the obstacles that face the mother in doing the induction of lactation or committing to 6 to 8 times pumping. Luckily, this part is easily fulfilled. These are from a message from one of my patients. She's sending me a picture of the milk. Alhamdulillah, الذي بنعمته تتم الصالحات رضع الخمس. This is another very famous kid. The mom is picturing the baby with every feed. These are the syringes full of milk, and she's picturing every time she's feeding her. This lady reached to breastfeed directly, exclusively, with no formula till 1.5 years. So these are achievements in the point of increasing the milk. So this is the first task ticked. Then comes the infant part. If they wish that the infant directly breastfeed, what's the obstacles facing us in this regard and how to overcome it? Direct breastfeeding after 3 months of bottle feeding, would this be acceptable? Can this be achievable? Let's see. We need a miracle to have a baby who's been having a bottle for more than 3 months to start latching. But luckily, miracles happen, especially in lactation and adoption. An infant at least 3 months old can latch miraculously. يعني in a scene that makes us all in tears, the mother, the father, and even myself, when they come early. We use the magic stick of hug hunger or emotional hunger. This is the magical window of opportunity when we get the baby to the breast even with no milk in the breast. The latch itself is something that the baby needs when he's coming directly from the orphanage to home. He's still emotionally hungry. He still needs the skin to skin contact. So he accepts to latch. And if this miracle happens, it's not the usual, but if this happens, we instantly put the SNS, supplemental nutrition system, or the Rylon tube to keep him at rest. Because if he's emotionally satisfied, usually after 1 or 2 weeks, then he discovered that this breast is not full of milk, then he might leave it again. So if this miracle happens in the first few days after taking the baby home, we use the SNS parallel to increasing the milk volume. So what if this didn't happen at the first sight? And this is a usual scenario because sometimes babies, when they move from an orphanage to wherever other place, even the other place, even if it was a better place, a more loving place, this change might affect the immunity, and babies usually get bronchitis and infection. The first week they move from an orphanage to a place, whether this place is good or not, because of only the change in the atmosphere on what they are used to. So sometimes this miracle is not as easy as what we see here. So comes the rehab, how to convince the baby to want to latch, and then how to strengthen the muscle of the baby. Here comes the infant behavior or the psychology part of the adoptive program, the induction of lactation program. We are faced with babies that have in utero experience of stress. Usually, the population of adopted babies here are usually babies that were found in the street or yani, in conditions that tells us gives us an idea about their previous in utero life or the few days that they experienced with their biological families. So we should keep in mind that sure, well, there were some sort of maternal stresses during the pregnancy, and this maternal stresses sure well made some fetal programming and cascade, stress induced cascade. We usually see the adopted kids having the post-traumatic stress disorder vulnerability just as kids who the mothers experienced catastrophic events like wars, like earthquakes, like grave stresses during the third trimester. So we should expect this. We should teach the parents how to deal with it, and we should detect which one is affected because actually not all kids are affected the same. We have this theory of the dandelion or orchid, which means that people that are not affected by the same insult in the same way. So we should detect which infant is affected by the probable bad stressful events he and his mother has been through during pregnancy and the 3 months of orphanages. So we have the neonatal behavior assessment tools, the NVO. These are the tools that makes us pick who is affected and reverse this affection. These are the tools that we use in the neonatal behavioral assessment, and this is a session of neonatal behavioral assessment. And these are our kids, not adopted, but I'm just here for to show what is the neonatal behavioral assessment. This is the team in Egypt working in neonatal behavioral assessment. So these are the problems. We should give solutions if we found that this baby is averting to touch, not like what we wish for, the baby who latched at the first sight. This is the a dream of every lactation consultant who's making induction of lactation, but this is not usually the case. So what if the baby refuses to be touched, refuses to be held, refuses to interact, refuses to have eye contact with the parents? And this is something we see a lot, unfortunately. So after picking the distressed child or infant, we start giving the moms some idea how to understand the needs and language of the baby, to teach her how to make the infant massage skin to skin and kangaroo care to calm the baby, and we'll know the other privileges of these, and by teaching the mom to talk to the baby. These are the simple tools that work like magic in induction of lactation. These are some pamphlets that were made by Brazelton Center in UK, and we translated it into Arabic that we use in teaching the mom how to understand this newcomer. Sure, we all know and we are all strong advocates of kangaroo and skin to skin, and we know the privileges of these at any age. And comes the magic sticks in adoptive nursing. If someone would ask me what is the most important tool in adoptive nursing, what is the most effective magic stick, I would tell them the baby massage. The baby massage, we do it like, we give it like a medicine. We do it like half an hour, 3 times daily at least. We teach the mother how to do it. We give them pamphlets or links, YouTube links, to do it in steps, not just randomly. And the more the better, for sure. Here's the pamphlet we give to the moms. It's exactly similar to post-NICU rehabilitation program that we do for incubated infants for a long time. We need to dilute the effect of stress they have seen, dilute the tension, and give them pleasant memories. And if you'd ask me why this is very important in adoption, adoptive nursing, as a step in getting the baby to the breast and to breastfeed, because this enhances the bond. When the mom do the baby massage, endorphins and enkephalins and happy hormones eject at the baby's brain, and they usually link the one who makes the massage with this pleasure, and here starts the spark of love, the spark of bonding, the spark of the baby wanting to stay at the breast skin to skin with the new mom, the adoptive mom, and this paves the way to us for later to convince him to latch, even if he is older than 3 or 4 months. This is a magic that we see in our clinics, and yani, we are blessed to see it, mashallah, alhamdulillah. So then we tell her to talk to him, to convince her to talk. Talking is a magic tool. We see it here, the papers and discussing the effect of talking in NICU, but it is the same in adoptive nursing. Sometimes the parents are afraid, they don't know what to say, but keep talking, eye contact, massage, to break the ice, to revert, to dilute the effect of whatever stress this adoptive baby has seen. Okay, after then having the milk volume and convincing the baby to latch, then comes strengthening the muscle, because we are facing something. Most of the babies are above 3 or 4 months. The sucking reflex is no more integrated. We call it the subsiding reflex. The sucking reflex that we put, we count on it in breastfeeding. Actually, it appears at 28 weeks gestation, matures in 34 weeks, and disappears approximately in 4 months, which is about the age that we take the baby home. So afterwards, the sucking or the feeding is an acquired skill. It's not a neurological reflex anymore. The tongue movement, like this cat, to evacuate the breast, is خلاص subsided because he's used to using the bottle for 3 or 4 months. But subhanallah, miracles do happen, and adaptive nursing actually shows us miracles. When we start the suck training, suck at finger, when we do the suck training massage, we actually restore this lost reflex together with skin to skin, together with the baby wanting to stick to the mother's lap and chest. All these together might revert the lost sucking reflex. Finally, we're left to face the post-adoption depression, and that is a big issue actually, because after the mom breastfeeds, after the baby is latching on the breast, and after she's getting the certificate from our facility that she already fed at least 5 whole uh, feeds, and she already got the adoptive the certificate from Al Azhar, some ladies feel depressed up to bringing back the baby to the orphanages, and this is a very, very يعني heart-aching situation. So dealing with this, the mom is not always a bad one. The parents are not, but she's facing deep depression, and خلاص, we know already these families, and I told you we're dealing with, mashallah, 300 adoptive families in our facilities. So we know she's a good person. She's been breastfeeding, but what happens? These have many backgrounds, but luckily we're not working alone in this. As we say in breastfeeding, generally breastfeeding is a team effort, especially the adoptive nursing breastfeeding is more of a team effort. We are collaborating with some associations. We here with our facility is collaborating with something association called الاحتضان في مصر. They do support groups to the mothers. They do psychological support, peer support, the whole family, the baby. They have communities that help the baby feel not different from their friends. Together with these associations, yes, we could do it, and we can decrease the postpartum depression of the adoptive youth. The achievement can be any stage, and every step on the path is an achievement. One fed is an achievement. Having a happy baby at his mother's lap is an achievement. But what they score as an achievement is reaching sometimes exclusively, directly breastfeeding, and many families, mashallah, can not so many, but we see it's not a ratio, but a number. They can reach up to 2 years of direct, exclusive breastfeeding after stopping the formula. May I remind you, this is where we started, and this is the gross boosted follow-up when we see one in the adoptive family, and this is actually the blessing that God gave us as doctors to see this progress and the happiness boosted to all, doctors included. This is our team, including doctors and NGOs, and these are my contacts. If anyone would like to see videos of mothers telling their stories, we had it on the channel. If anyone is interested in knowing what's the behavioral assessment or seeing more stories of the mother, you can join us and you can call me anytime. And thank you so much.
Thank you very much, Dr. Asma. Anyone has any questions to Dr. Asma? Any questions for Dr. Asma? Dr. Safinez, do you have questions for Dr. Asma?
Yeah, thank you very much, Dr. Asma, on highlighting these details, actually practical details. Thank you very much, actually. Really, how the baby will get used to the breast again, how will he accept or no, how mother and her psychological new responsibilities, psychological, I mean, fragility. So that's really very important points to highlight. Can you please tell us about that lady who was successful to breastfeed for 1.5 years? Was that induced lactation really, or what relactation, or what?
Dr. Amal, can I share her video? Because this specific mom, recorded a video to us. If it's in 3 minutes, can I
Yes,
put it
yes,
on screen?
yes,
Okay.
yes.
And the answer is from the mother's word, Dr. Sahinas. I'm happy to
Okay,
share
okay.
this, and I have the consent of her. I
Okay.
felt like I might use this in a glimpse. And I would again share screen. Special dedication to Dr. Sahinas.
Thank you. Thank you.
Okay. Just tell me if it's on screen. Is it on screen?
Yes.
Yes.
Okay. So this is
MashaAllah.
one of our mothers. It's
MashaAllah. صوتها مو طالع.
من 5 سنوات خدنا انا وجوزي قرار مهم ونفتح قرارات حياتنا هو ان احنا نكون اسره بالكفاله والاستقرار. لكن واجهتني تحديات كتير قوي. اولهم ان انا هدخل بنوته مبدئيا. التحدي الاول ده ان هو البنت بشكل ديني وبشكل عاداتنا وتقاليدنا، البنت ازاي هتكبر داخل الاسره، ازاي هتعيش حياتها بشكل طبيعي مع والدها او مع اخوها او ايا كان مع اقاربها. هنا ابتديت سمعت عن الارضاع وعن التخصص الموجود اللي هو بشكل كبير وقتها الحمد لله كان معروف، هو تخصص الرضاعة الطبيعية، استشارة الرضاعة الطبيعية. بالفرق جيت على طول للدكتورة وبدأت أعرف أنا إزاي أهتم برضاعة طبيعية مع طبعا التحديات الباقية اللي كانت هتواجهنا، وهي إن الطفل علشان أستلمها عمرها بيكون لازم يكون 3 شهور داخل الطفل. ازاي الطفل هتقعد 3 شهور تاخد بكورونا ولبن صناعي، وانا هاجي بعد ال3 شهور ده اغير تحدي كبير جدا جدا، لان انا كنت شايفه ده نتيجته لبعدين. انا مش بس عايزه ابقى ام، مش عايزه بس اشبع بنفسي وبس، انا عايزه ادي بنتي حقها في الحياه، حقها في التربيه وحقها في الحنان والمشاعر الكامله. مش هطول عليكم، بدأت كورس الرضاعة ولكن واجهني برضه تحدي تاني، إن أنا ما كانش مناسب ليا إن أنا آخد هرمون عامل هرموني، فبدأت الكورس بوقت قصير جدا وسريع جدا، وخدت الكورس السريع وابتديت عند عمر 6 شهور إن أنا ابتدي أرضع حور رضاعة طبيعية كاملة. مع الدكتورة احنا اشتغلنا كمان على عضلات الفك عند الطفلة، لان طبعا كان في كورونا، فاحنا اشتغلنا على عضلات الفك، اشتغلنا على التعامل بيني وبين الطفل بشكل معين، ازاي هندي بكورونا ولكن بشكل بسيط عشان نقلله ونوصل ان احنا نمنعها خالص ونمنع اللبن الصناعي. وهو ده اللي حصل، مش وصلنا ل5 رضعات مش بعيد. حققنا في الجانب الديني وكمان حققت الجانب الهرموني، ان انا ابتديت ارضعها رضاعه طبيعيه مباشره دون اي لبن صناعي. اهم حاجه انا عايزه اوصلها وعايزه اقولها هو ان كل التعب وكل الاصرار وكل اللي احنا عملناه خلال ال5 سنين انا وجوزي، انا دلوقتي شفت نتيجته ان بنتي بطلة جمهوريه، مركز اول جمهوري في الجمهور الفني. تعب كبير مرينا بيه، مشاعر كتير مريت بيها، يأس وأمل وإحباط وحب وفرحة وسعادة، لكن لما شفت نتيجة ده دلوقتي أنا حقيقي بقول كملوا ما تيأسوش. القرار ما كانش سهل أبدا، هنمر بظروف كتير لكن نتيجتها حلوة أوي. من السهل أن تملك لأصعب الأشياء تنتهي في حياتنا. احنا حاليا خدنا قرار تاني مرة، معانا بنوتتنا بالكفالة الثانية أخت حور هي نور. دعواتكم في التجربة المرة دي تنجح ونكمل رضاعة طبيعية لمدة 2 سنين كاملين من غير أي لبن صناعي. شكرا دكتورة أسماء صادق، شكرا لكل الحضور. أمي مصطفى والدة حور ونور من مؤسسة
Okay, so that was it.
شكرا يا دكتورة أسماء.
العفو يا فندم. hopefully this answered
شكرا
Dr. Fatma's question.
شكرا لمشاركتنا هذه التجربة الجميلة يعني.
Anyone else has any questions for Dr. Asma? So we have listened to many experiences from many countries, and also the international experience from Dr. Carlin. We listened to Malaysia, Dr. Zahra. We listened to Dr. Safinez, what they do in Saudi Arabia, the only country that regulates the process and documents it in a very what should I say, very disciplined manner. Also, we listened to the Egyptian experience from Dr. Asma, and I think we have listened to the biology and the emotions dialogue that happens and brings about this wonderful experience from Dr. Rania. Thank you for listening and attending, and thank you for all our speakers. And I think I hope you have benefited from this webinar and you find it interesting. Thank you, everyone. Goodbye.
Thank you, Dr. Amal, and thanks to all the speakers and the audience.
Thank you, Dr. Safinez.
My thanks to Dr. Fatma, of course.
Thank you.
Bye.